Hi, today I am so elated in meeting you with JIP's 3 p.m. 3-point medics program. We have been learning about hyponatremia. Last session we saw few things about hyponatremia. So I want you to recall that plasma osmolality or plasma solute concentration is predominantly contributed by sodium concentration, even though many solutes including sodium, potassium, chloride, bicarbonate, urea and glucose are present. It is the sodium that contributes 90% of plasma osmolality or plasma solute concentration. So for all practical purpose for us, plasma osmolality is nothing but it is serum sodium concentration. That's why if somebody has hyponatremia, you can spontaneously assume that patient has reduction in plasma osmolality. If somebody says that patient's serum osmolality has come down, then you have to think in such a way that serum sodium concentration has come down. So this is the one we saw yesterday. Now we are going to some more points about hyponatremia. As I told you earlier, it is a water excess that is responsible for hyponatremia in most occasions. Your serum sodium may be normal because of few situations which may accumulate excess water in your body, which can dilute your normal serum sodium, resulting in hyponatremia. So that's why in any hyponatremia management, fluid restriction is part and parcel of management of hyponatremia other than hypovolemic hyponatremia. When you are sure that you are dealing with hypovolemic hyponatremia like severe diarrhea and vomiting, otherwise in many occasions it is a fluid restriction that would be very helpful in elevating your sodium concentration. Now we are going to see how the water excess occurs in our body, which is responsible for diluting your normal serum sodium, resulting in hyponatremia. Point number 1. When you take excess body water, naturally your sodium level will be diluted, resulting in hyponatremia. So there is no second thought on this. But how much of excess body water you are supposed to consume to dilute serum sodium, resulting in hyponatremia? It has been estimated that if you take 18 liters of plain water or free water, then your serum sodium can be diluted, resulting in hyponatremia. But is it possible to take 18 liters per day? A normal person may not be and cannot be. So there are few situations where people will take 18 liters of water per day or 750 ml of water per hour for many hours may result in rapid decline in sodium level. So what are these few situations can cause this abnormal excess water accumulation, resulting in hyponatremia? One is psychogenic polydipsia. When somebody has features of schizophrenia, they tend to take water more than 18 liter may result in hyponatremia. And second one, some few situations where a normal person will be forced to take water more than 18 liter. For example, marathon runners and the drinking competition. So these are the few conditions where you are taking water exceeding 18 liters to make hyponatremia in our body. And second one, now you are taking normal water, okay, but our kidney is not able to excrete this water, resulting in hyponatremia. You are taking very normal water like 2.5 liter, 3 liters per day, but kidney is not capable of excreting water, resulting in dilutional hyponatremia. So if that situation should occur, one of the mechanism is increased ADH production. So when you have increased production of antidiuretic hormone, so the name itself implies it is against the diuresis. So this antidiuretic hormone acts at collecting tubules, and that resulting in enormous water absorption in our body, resulting in hyponatremia. So when you have excess ADH stimulation, our kidney is not able to excrete water, resulting in hyponatremia, where you will have excess ADH secretion. So normally ADH should be secreted only in two occasions. See, our kidney will not excrete water in the form of urine only in two abnormal situations. One, when you have hypovolemia secondary to diarrhea and vomiting. So when you have severe diarrhea and vomiting, due to which your total body water or especially your intravascular volume is getting decreased. Okay, there is no adequate plasma in your intravascular compartment, resulting in almost hypotension. At that situation, our body will produce ADH secretion to absorb water from the kidney to avoid urine formation. So it has been observed that when your intravascular volume is decreased by more than 15% from your baseline value, our ADH will be stimulated. So what happens once ADH is stimulated? It absorbs water. Because of that, there will be water accumulation in your body. Hyponatremia may ensue. This is one mechanism. And second one, any organ failure, you will have edema. For example, even cardiac failure or cirrhosis of liver and chronic kidney disease or acute kidney injury, where what happens, your total body water may be high. I mean, you will have edema, but what happens, whatever the fluid that is present in the intravascular compartment or in the blood vessel will be evacuated out of blood vessel into the interstitium, causing edema. So here your total body water may be high in the presence of organ failure, but intravascular compartment, your volume is very low. So our body will sense only the depletion of intravascular volume. It will never sense how much of water you have in your body. It will assess only the intravascular volume. In all the organ failure, because of edema, your total body water may be very high, but within the blood vessel or intravascular compartment, what happens? Your plasma volume will be minimal, because all the fluid will be extravasated into the interstitium as edema. So this intravascular volume depletion will be sensed by kidney, then our body will secrete ADH, and it thinks that as if there is no water in our body, but truly speaking, there is not much water in the intravascular compartment, but in the interstitial compartment you have so much of water in the form of edema. But body will sense in such a way that there is no adequate water in our body, so it will stimulate ADH. So ADH will be stimulated, more water will be absorbed, so which results in more and more total body water. Then ultimately edema formation will be more, then overall sodium level will decline because of increased ECF volume. So ADH will be stimulated by two mechanisms. One is when you have decreased intravascular volume. It is a true intravascular volume in the case of diarrhea and vomiting, or there is a false decreased intravascular volume in the case of all the organ failure. So here the ADH will be stimulated. But in the absence of both these conditions, there won't be any hypovolemia, I mean diarrhea or vomiting, There won't be any true hypovolemia like diarrhea and vomiting, or there won't be any organ failure, but without any reason there will be spontaneous secretion of ADH. So this ADH will be secreted inappropriately, because appropriately means there should be depletion in the intravascular volume, but here there is no such incidence. So what happened, ADH will be automatically secreted or inappropriately secreted or relentlessly secreted in the absence of any reasonable factors. This is called syndrome of inappropriate ADH. When you have brain disorder like meningitis, encephalitis, or brain tumor, or brain abscess, or whatever reason brain disorder, or some pulmonary pathology, when you harbor lung tumor or lung abscess, even tuberculosis. So without any reason, this ADH will be stimulated, resulting in water accumulation in our body, resulting in hyponatremia. So today we have seen the water accumulation will cause normal sodium making diluted one, resulting in hyponatremia. This excess water accumulation can be due to either excess water intake or because of ADH stimulation. We will see the rest of the features of hyponatremia in next session. Thank you.